One second. Professor Hiroshi's message, please. Asmita, 1 minute it is still.
I am Shinichi Hirose, President of AOCNA. I am honored to invite you to the 17th AOCCN in New Delhi, India, from September 16th to 20th, 2025, where we will explore the latest advancements in our field. This Congress is a unique opportunity to network with child neurologists from across Asia and Oceania. It's a chance to build connections and share knowledge crucial for advancement of our field. India, with its rapid economic growth and rich cultural heritage, offers memorable experience both scientifically and personally. I firmly believe that face-to-face interaction are key to overcoming global challenges. I encourage you to join us in New Delhi to deepen your professional relations and foster collaborations. I look forward to seeing you there. Thank you.
Mahesh?
Yes. Good evening, everyone. I welcome you all for our next Meet the Expert webinar. And today we have an interesting talk on neonatal strokes by Dr. Sonika Agarwal. I'd like to request our President, Chafal Equality Ma'am, to introduce the speaker for today, the expert for today's session, and the moderator for today's session. Over to you, ma'am.
Welcome to this amazing session. So we would be having the speaker, Dr. Sonika Agarwal, who is Associate Professor of Neurology and Pediatrics, Clinical Director of Fetal Neonatal Neuroscience, Section Head Neonatal Neurology at the Children's Hospital of Philadelphia, and Perelman School of Medicine at the University of Pennsylvania. Besides being a fellow of American Academy of Neurology, she is currently chairing the pediatric subsection of the American Academy of Neurology and has lots of achievements like leader in fetal neonatal neurology, and has collaborated to develop the first fetal neurology consortium and subsequently the fetal neurological special interest group at the CNS. And she will be delivering a keynote address on fetal neurology in the upcoming conference of AOCCN in Yashobhoomi in September this year. She has led the work to publish practice guidelines in fetal neurology with the global team and to guide the postnatal care of these children. Thank you so much, Dr. Sonika, and for joining us. Welcome. And we have experts. We have Dr. Tugba Hirfanglu from Gazi University, Faculty of Medicine, Department of Pediatric Neurology, Ankara, Turkey. Her special interests are neonatal neurology, besides many more like pediatric epilepsy and epilepsy surgery. And she's a member of Turkish National Pediatric Neurology Science Society and has general editorship of many journals. Thank you, Dr. Tugba, for joining. And our dear friend, Dr. Lokesh Lingappa. I'm currently president of AOC in India. He's the president-elect of AOC in India and a dear friend and a very well-renowned pediatric neurologist. And he's a consultant child and adolescent neurologist in the Rainbow Children Hospital, Hyderabad. And he has done his DM in neurology from NIMHANS, and then has some training in UK as well. And he has been awarded the best outgoing neurology student from NIMHANS and has many credits and accolations about, and very well renowned. Thank you, Lokesh. And we have our young bride, Dr. Meenal Kekatpure. She is a senior consultant, pediatric neurologist, lead division of pediatric neurology in Department of Neurology, Mazumdar Shaw Medical Center, Narayana Health City, Bangalore, and clinical research areas are pediatric stroke and neurovascular disorders, and morphometric brain imaging in pediatric populations, and gene therapies, and neuroimmunology and neurodevelopment. She is a member working committee on the Pediatric Stroke Readiness International Pediatric Stroke Organization, and assistant editor of the Journals of Annals of Indian Academy of Neurology, and very other acclamations, and also a lot of publications. Thank you, Dr. Meenal. And to moderate the session, we have our dear friend, a very renowned pediatric neurology, Dr. Praveen Kumar, who is head and senior consultant pediatric neurology at the Institute of Child Health, Sir Gangaram Hospital, New Delhi, who's done a postdoctoral fellowship in pediatric neurology. And currently, he's written a book on pediatric EEG, and areas of interest include neonatal stroke. Praveen, up to you now.
Yeah, and good evening to all of you. And it's a very important session today. I think the perinatal stroke is one of the common areas of interest, which includes our pediatrician and neurology colleagues also. And we understand that this is one of the most common age where we get the strokes, and we have a lot of dilemmas about the diagnosis, definitely about the management part also, the investigations and how to follow them up. So I think I'm already introduced about Dr. Sonika, and we invite you for this academic session. Dr. Sonika, please.
Thank you very much for this kind invitation. I am going to now share my screen. So, okay, so you have the presenter mode now. Can you see the big and slides advancing?
Yeah, we can.
Okay, so thank you very much for this kind invitation. I'm looking forward to a very engaging discussion. So I will try to give an overview of the pathophysiology and risk factors associated with perinatal neonatal stroke, go over some clinical cases, how they present, and what the outcomes look like, and what we do in terms of rehabilitation. And I'll discuss some common case studies for learning for all. So it's perinatal or neonatal stroke is a diverse group of focal cerebrovascular injury to the early developing brain. And there's about 5 million people worldwide. And the incidence can range from 1 in 1,600 to 2,300 live births. Majority of them can happen any time from 20 weeks, the period of viability of fetal life, to early postnatal life, which is the neonatal period from 0 to 28 days. But some can present after that also. And while the babies may sometimes not present with symptoms right away, but this has lifelong implications in terms of the outcomes and the economical and emotional burden for families. So broadly speaking, I'll be focusing on the most common types of perinatal stroke. There are 6 types, 3 types present in the neonatal period, which is about half of the total neonatal strokes. And usually these children will present with neonatal encephalopathy, and we'll come to that. And the first week of neonatal life, the 0 to 7 day period, is the most focused lifetime period where these children will present, the babies will present with stroke. Those who do not present in that period present at a later age with what was initially known to be a congenital hemiplegia, and they present with weakness on one side in proportion to the injury on the opposite side of the brain. There's other associated complications, seizures and epilepsy, intellectual and learning issues, language challenges, and social and behavioral issues with other factors associated along with the motor disability. So if you look at the timeline, the periventricular venous infarction, that is more of a in utero fetal injury. So it can happen from 20 to 32 weeks. Then there is the neonatal period, 0 to 28 days. Of that, the first few days is the most high-risk period where majority of these babies will present. The NAIS, which is the neonatal arterial ischemic stroke, the neonatal hemorrhagic stroke, and then CSVT is a special category, but I'm mentioning because these are also presenting in that period, cerebral sinus venous thrombosis. So usually that's the neonatal period, or those who do not present here can present usually at 3rd or 4th month of life with the focal motor disability. Now, a neonatal arterial ischemic stroke, it's rare, but even with multiple epidemiological studies, the exact cause is still a hypothesis. So it's a combination of factors. Usually there's difficulty in transition from fetal to neonatal life. Majority are thought to be due to a thrombus that embolizes from the placenta to the brain, blocking the vessel. Very rarely, extremely rarely, and it's only case reports where any birth injury or the craniocervical arterial injury, which is extremely rare, and we'll come to those cases. So not knowing the exact timeline and the exact cause often leaves the medical team and the parents with uncertainty. And there's also this medical legal aspect of it for the obstetricians and the caring neonatologists. So really counseling and proper testing at the right time when a baby presents with symptoms is key. Now, there were earlier reviews which almost implicated every symptom that could be associated with the, so intrapartum fever, medical complications, fetal heart deceleration, cesarean, instrument deliveries, low APGAR scores, all these were associated risk factors. But there were, this is one study where multiple multivariate models were analyzed to look at the risk factors and predictors. And it was a large case control study. And what the researchers found, so in 134 babies with 576 normal neonates, what was the high risk factor? So the highest was perinatal inflammation and infection, chorioamnionitis. So there was a preceding inflammation and infection. So the OR ratio, odds ratio was almost 10. Multiple pregnancies, male sex, preterm birth, small for gestational age were other high-risk factors. And then they also mentioned the low APGARs, hypoxia, and other instrument delivery, which were seen to be commonly associated. So the study pointed to the importance of in the inflammatory process, and there was a there was an underlying fetal placental insufficiency. And then over and above that, preterm birth or multiple birth or any other medical or obstetric complications that led to further complications in transitioning from the fetal to the neonatal period. However, chorioamnionitis and small for gestational age were like the predominant risk factors that were identified. And then the authors then drew a flow chart to understand that there's underlying obstetrical complications, perinatal inflammation that is associated with preterm birth and small for gestational age, male sex and primiparity add additional risk factor, which then already identify a baby who's going to be predisposed to perinatal stroke. And then these are the babies who will end up with the requiring resuscitation and care and support, also probably requiring cesarean and vaginal operative or instrument delivery. And these are all interlinked because, you know, with the if there is a delay with the decision making or how a baby delivers, that can further aggravate and worsen the picture. So perinatal inflammation by large was the highest risk factor, and there was also multifactorial features that were mentioned. that usually there's not a single identifying risk factor. So most of the babies we've seen will be presenting with low Apgars, fetal heart abnormalities requiring emergency section. Meconium is usually identified, and often there'll be a history of prolonged second stage requiring instrumentation. Now, these days, researchers are also looking at the placenta for all these babies who present with neonatal encephalopathy, and especially with neonatal stroke. This is a small study. However, they found that there was significant abnormalities in the placenta in terms of velitis and fetal inflammatory response syndrome, intense fetal vasculitis that was seen in the placenta for these babies. And now looking at the direct vessel trauma, this is extremely rare. It was almost thought to be not existing as a predisposition. However, in 2023, there was this case report that was published in Pediatric Neurology, and they mentioned their index case along with 9 other cases in the literature. 8 out of 9 had instrument or traumatic delivery or emergent C-section. And then usually the babies presented with seizures or respiratory issues, hyperreactivity, change in exam. And then the MRI identified the stroke. There was carotid artery dissection in a few, and then also the antithrombotic treatment was done in 2 out of 9. And these were usually extensive strokes. So the conclusions were that while it is rare, it's often preceded by a really traumatic birth, instrument delivery, where we see significant signs of birth injury presenting with seizures and encephalopathy, and with a poor exam that led to the MRI. So this was the index case that was published, and you can see the area of the stroke, and they found a clot in the vessel. The baby had antithrombotic therapy, which is very unusual for neonatal strokes. Majority of these children, the practice is because usually the clot has already canalized by the time the stroke happens and they present. So this is a one-odd case where anticoagulation was done due to the vessel wall injury. So these are again extremely rare, and only 9 cases have been reported. So coming to the types of neonatal strokes, the most common type of neonatal arterial ischemic stroke is where they will present in one of the major blood vessel walls. You can see this diagram here. That's the left middle cerebral artery. This is the diffusion weighted images. So DWI, where the diffusion of the water molecules through the injured cells is impaired and they appear bright. And for student learners, so it's easy to remember anything white and bright. So DWI on the diffusion scan is the area of the stroke. You can also see corpus callosum is affected and some of the descending fibers with the Wallerian degeneration. So this is the most common type. 80 to 90% of the babies who present with neonatal stroke are this type. Usually there's a focal area of infarction. Majority will present with seizures on the 12 to 72 hour window. So with the hypoxic ischemic encephalopathy, they'll present right away in the first day or first 12 hours. Neonatal stroke, usually majority of these babies will be roomed with the mom, and then they'll be presenting with seizures or abnormal movements or a poor feeding or poor exam that leads to alerting the medical team. So encephalopathy is the presentation. They're irritable, lethargic, abnormal tone and feeding issues. Imaging. So coming to imaging, MRI is the gold standard, and diffusion sequences like I presented along with the ADC, the apparent diffusion coefficient. And then MRA is usually with neonatal stroke, it is indicated. It's not always routinely done. And so many times when the baby goes to the MRI, they get a stroke is identified and they are back, then and if they are doing well, not necessarily that a MRA gets added. But the book recommendation remains that you add a MRA, and MRV, the magnetic resonance venogram, is based on case-by-case basis based on clinical suspicion. The MRA is usually normal. True arteriopathy is very rare. And so that's why it's not always done. Now, region of occlusion can be seen, flow defects can be seen, regional hyperemia can be seen, and the area of the injury, the size of the injury links to the outcome. So it is very important to counsel the families. You can see the anterior cerebral artery division, on the left MCA, the PCA, the posterior cerebral artery. So all these are linked to the area where future motor deficits can be predicted. Epilepsy outcomes are difficult to predict. And early outcome prognostication from the acute imaging in the acute neonatal period is helping us select the patients for some trials and emerging early neuroprotective therapies. Now, what are the other risk factors? So we talked about the hypothesis, we talked about predisposing factors. There's another big population that is at high risk for stroke is the babies with congenital heart disease. So any baby with a congenital heart disease is at high risk. It's a well-known risk factor. And echo is standard of care in many centers where available freely for any patient that presents with a neonatal stroke if it's diagnosed in the neonatal period. And the evidence, however, says that it's unlikely to change management. Most findings are within the normal spectrum, so it's not routinely done. But it is a consideration, especially if there is an abnormal murmur or exam that suggests a heart disease. The other risk factor is infection. So bacterial meningitis. So it's stroke complicates 17 to 43% of pediatric childhood bacterial meningitis. It presents with seizures, encephalopathy. The mechanisms of stroke are usually there's arteriopathy. They can be associated coagulopathy and predisposing to clots that get propagated to the brain. And you can also see thrombosis of the sinus venuses. Group B streptococcus, so GBS meningitis is one common presentation. Prompt antibiotics is indicated. A recent study has suggested anticoagulation is safe. However, again, it's a case-by-case basis. And there are some studies looking at use of steroids for these children. Now, the risk of association with thrombophilia. This has often been considered. Initially, these were being done more commonly, the testing for thrombophilia. However, 3 recent studies demonstrated that there was a lack of association, and the testing is usually indicated on a case-by-case basis. So if a baby who's presenting with stroke is with seizures or stroke was likely to get a blood count, platelets, and the basic test that can be done is the PT, PTT, and INR, and basic metabolic panel with some calcium, magnesium, liver function, basically looking for any other predisposing features for any infectious or metabolic disorders which can cause acute neurological symptoms. However, like a lumbar puncture, again, case-by-case basis, if you are suspecting sepsis, if there's high preterm labor or chorioamnionitis infection, then case-by-case basis that is considered. Not all babies majority will not get all these tests. Metabolic and genetic cases are in some rare case-by-case basis where the imaging findings or the clinical exam are not matching, and they suggest that. Thrombophilia studies, again, if a cerebral sinus venous thrombosis that is unprovoked, there's a strong family history of thrombosis, recurrent pregnancy loss. So such factors in the history lead to consideration for the thrombophilia testing, and usually hematology consultants get involved for further. But this chart shows the whole big battery of tests for the hematological labs. It's like a big order of all these factors that can predispose to problems with thrombophilia. Now, treatment is supportive care. There's not a specific treatment like anticoagulation or anything that is done for the adult stroke. So NICU management and the intensive care stabilize the infant, airway, breathing, fluids, supportive care, maintain normothermia, normotension, and then anti-seizure therapy. So diagnosis and treatment of seizures actively in real time is really important. Video EEG monitoring, continuous EEG monitoring is the gold standard in neonates. As you all are aware, 50 to 60% of the seizures can be subclinical and can be missed. But majority of the children with neonatal strokes who present at the neonatal period, they present with seizures. And the other findings are the encephalopathy, poor feeding, and abnormal tone and exam. Now, seizures resolve over the next few days, and usually the infant is discharged after weaning off the medication. And the old practice was to continue it till the clinic visit, but this is also now being treated as any acute provoked seizure due to, like we do for HIE, hypoxic ischemic encephalopathy. So for strokes also, these are acute symptomatic seizures, which usually resolve in the first week. Very rarely there'll be a couple babies who will be requiring multiple medications. Phenobarbital, again, the seizure pathway remains the first line. There are emerging trials. I'm just mentioning the names. Erythropoietin, darbepoetin, looking at stem cells, mesenchyme. These are all very preclinical stages looking at neuroprotective therapies. Now, the other part of the neonatal stroke that does not present in the first few days of life or in the first month of life is the presumed perinatal stroke. So a baby who does not present with symptoms at birth, but goes on to develop and then presents with early handedness. So the most common symptom is unilateral weakness. So either the arm or leg or both, parents will often come to the pediatrician saying the baby is only rolling from one side, or they are tight on one side, they have a little torticollis, or they're not reaching with one hand. So emerging developmental hemiparesis, motor asymmetry. And then the less common presentation is like someone who has a small stroke can really escape these motor effects depending on where it's located, and only present with milder learning and other issues, seizures in later life. So that's a less common presentation. So typically, such a child will get referred to the pediatric neurologist, gets a MRI, and you diagnose the lesion. The other common type of the neonatal stroke is the hemorrhagic stroke. So the hemorrhage can be anywhere in the temporal lobe. This is an MRI showing like the frontal lobe. This is a susceptibility imaging showing in the basal ganglia, thalamic. So they can be in any areas, parietal, frontal, temporal, and depending on the area, it predicts your future deficits. However, these babies also present with similar symptoms. Usually it's seizures, encephalopathy, focal motor seizures. So typically very commonly associated with these stroke or hemorrhagic or arterial ischemic, where they'll have focal motor seizures, they'll be encephalopathic, and the incidence is less common than the arterial ischemic, 1 in 6,000. And then sometimes they can be hemorrhagic transformation of an arterial or a venous infarct, but majority are usually primary idiopathic hemorrhagic strokes. Now, in an unstable baby, sometimes cranial ultrasound, bedside ultrasound, or a CT can be done if MRI is not available, but the gold standard for any diagnosis remains the MRI, magnetic resonance imaging, similar to the arterial ischemic stroke. And the vessel imaging is added. If you're suspecting possible thrombus, you do that. MRA, again, based on the vessel imaging. Now, thalamic hemorrhages with intraventricular extension of the hemorrhage, you have to look for clots in the deep cerebral sinus venous thrombosis. So this is one indication where the vascular imaging is indicated, including MRV. Temporal lobe is most common location for idiopathic neonatal hemorrhagic stroke. Many times the babies with the temporal lobe lesions, they can present with apneic seizures. That's a common presentation we've seen. Now, with fetal neurology coming into view, many times, it's evolving and we are doing prenatal scans. So this, I'm just mentioning, this was a ultrasound done in pregnancy that picked up cystic encephalomalacia and multifocal hemorrhages. And then the MRI showed this, you look at the temporal lobe here, it shows arteriovenous malformation that was bleeding and causing multiple multiphasic brain injury leading to cystic encephalomalacia. And there was family history of hemoptysis, and multiple members had what we call hereditary hemorrhagic telangiectasia. So very rare case, and they underwent palliative embolization. But cerebral AVMs can be a cause of hemorrhagic strokes, which can present fetally or neonatally. The rate of AVMs in patients with HHT is as high as 10%. Now, the other counterpart that presents late is again the presumed perinatal hemorrhagic stroke. The other conditions that can predispose are neonatal alloimmune thrombocytopenia, disseminated intravascular coagulation, and then any coagulation, so hemophilia, and the hematological workup is indicated. Now, risk factors, again, they pinpointed, this is a busy slide, I'm not going to, but it was similar to difficult transition from fetal to neonatal life with all these factors with fetal variability, emergent C-section, instrumentation, birth-related trauma, all these had been implicated. Now, looking at this question always comes when you are counseling a family who has undergone a vacuum or forceps extraction. And there was this paper looking at protracted vacuum extraction and neonatal intracranial hemorrhage. This was a large database, a Swedish study from the birth registers, and case control study from 1999 to 2013. And they concluded from this study that easy extraction can never be guaranteed beforehand, right? Like there's no way to predict, but some extractions just turn out to be more complicated than others, and protracted extraction, the number of pulls. So in this study, they found a strong association between protracted extraction and intracranial hemorrhage, and recommended adherence to safety guidelines. And even re-looking the guidelines and re-evaluating, because there were some babies where the team adhered to the guidelines, but they still ended up having a hemorrhage. So extractions exceeding 15 minutes were among 33% of the cases versus 5% of the control. More than 6 pulls were associated. And so really you have to be very cautious when these factors are being considered in the second stage of labor. And they also said that when there is significant birth trauma, then possibly consider imaging on a case-by-case basis. So this is an example of a patient where a term birth, failed vacuum extraction, converted to C-section, then suspected hypoxic ischemic encephalopathy, and found to have a left parietal fracture. So really traumatic birth, left parietal fracture with a large epidural hemorrhage. And you see this underlying hematoma. And the baby required multiple medications for status over a week of multiple medications, including infusion with midazolam. And the further diffusion scan, the underlying parenchymal injury was mainly just due to compression from the hematoma, but this was from the failed vacuum with prolonged extraction. So these are kind of rare, and this hemicranectomy, which is done for adults, is usually not done in babies. There's enough room. I've only seen 1 or 2 babies getting, and this was one of the cases where the neurosurgical involvement was there. Now, neonatal hemorrhagic stroke. So they can be mass effect and need for neurosurgical intervention. Management is supportive. neurosurgical intervention is extremely rare. So majority of the children babies will not need it. Supportive care, similar to the other types of stroke, with hemorrhage, with intraventricular extension, careful monitoring for hydrocephalus. And head circumference to be monitored. Sorry, and neurodevelopment and language outcomes with cognitive and all need to be monitored just for any other stroke, the rehabilitation. But some of these children, obviously, based on the hydrocephalus, can require neurosurgical evaluation for shunt monitoring. Now, I'm going to moving on to the next one type is the periventricular venous infarction, right? So there's a germinal matrix which bleeds, and that causes pressure injury and seepage of blood into the parenchyma or into the ventricles, what we call periventricular venous infarction. And this is an MRI where you see the expansion of the ventricle with the white matter injury around it. And these are usually in utero. So they can happen earlier in any time from 20 to 32 weeks. They can lead to cystic encephalomalacia or porencephaly, ventricular dilation. And then depending on the area of the injury in the white matter, motor deficits can also be seen. Majority of these children will probably not present with seizures or encephalopathy at birth. However, there are some who are really small for gestational age or growth restricted, and they present with encephalopathy and poor feeding that ends up with an MRI that shows this in utero injury. However, many will not present with acute symptoms, and they present with congenital hemiplegia, which correlates with the in utero version of the same type of stroke. So the opposite side weakness, about 50% of the presumed perinatal strokes can be due to this isolated motor symptoms. Again, or unilateral weakness, leg symptoms can be more common in this kind of stroke, and I'll show you some scans later on. And these are thought to be related to genetic or in utero. There are certain genetic conditions, collagen mutations, which can predispose to this kind of injury, white matter injury also. Now, we're not going in details, but just to mention the cerebral sinus venous thrombosis, and then it can be associated with frontal hemorrhages, focal underlying hemorrhages where under the thrombosis, or with deep thalamic or basal ganglia hemorrhages, again, which are an indication for adding the MRV and MRA to your MRI scan. So here also you're seeing the pictures correlating with the hemorrhages, and these babies will present sometimes few days after birth. There is a classic presentation where exclusively breastfed dehydrated baby comes back on the third, fourth day with hypernatremia and dehydration, and they present with the sinus venous thrombosis leading to hemorrhage and then seizures. Now, it is a relatively less frequent condition. Estimated incidence is 1 to 12 per 100,000 live births, male predominance, seizures in 50% in the first few days of life. MRV will be crucial in the diagnosis, and then we already talked about the thalamic hemorrhage and due to obstruction of the deep venous system. This is again just your exam during the counseling and for the future motor prediction. And so again, you are seeing the diffusion images here. So this is more the posterior parietal. This is more the anterior side. You're seeing the ADC here. And so these are images which usually we share with the families while counseling for any future deficits. If someone has injury in the occipital area, then obviously vision issues will also be discussed. Now, DWI is the most sensitive visualization of the infarct, and it's the brightest and usually follows the vascular territory. You can also see Wallerian degeneration from the descending fibers, and sometimes edema can be seen with the gray-white sulci becoming less prominent. Now, there are some atypical, so we know the classic type of stroke with the vascular boundaries, but look at this picture. So this is like the both sides on the back occipital, but this is more the watershed type of stroke. So you're seeing some of the deep matter and at the junction of the ACA, PCA, MCA. And so these are some atypical patterns we can see. And then also sometimes you see a combination of HIE and stroke. So that again goes into the counseling of what the outcome could be. Now, this is another example of a premature baby, 32-weeker, C-section for non-reassuring fetal heart, and had some bruising from extraction, premature rupture of membranes at 28 weeks. So again, that preceding premature perinatal inflammation, remember the risk factor in the prematurity, and low Apgars required some support. MRI led to, because of the encephalopathy, led to this picture identifying the stroke. So again, left MCA, and then we were seeing on the susceptibility images, there was this hemosiderin. So you're seeing the blood on the susceptibility images in multifocal areas. And so effect will be possibly like the right-sided hemiplegia. Also with the deep white matter injury, you can see a range of language and learning deficits, which can only be clear with time. And that's we always counsel the families for that also. Now, this is another child who presented, who had been actually following with orthopedic. So this is the type of periventricular venous infarction that I was showing in the other type of in utero strokes. And so this child was being followed and was given orthotics, was a delayed referral to neurology, mainly with more of the lower extremity weakness. So when we did the MRI at 18 months of age, this was the picture here. You can see the ventricle is bigger. You see this ischemic injury this is a remote scarring. So remote injury in the fan shape, medullary veins are here. And then you see this periventricular injury, which is in the descending fibers of the leg. And so it has the asymmetric gait, but speech, language, cognitive development has been on track. But you have to be careful when you're counseling these families. So like if you see injury on both sides in the white matter, symptoms of learning, cognitive challenges, ADHD-like symptoms, attention and concentration, slower processing, all can be seen with extensive white matter injury. Now, this was another 10-month-old with history of neonatal seizures. And then there was history of premature rupture of membranes, fetal deceleration, low Apgars requiring seizures and phenobarbital treatment. And then presented, so on the MRI, there was this large stroke. You can see descending Wallerian degeneration in the peduncles here and the descending fibers. And this was a baby who presented with hips arrhythmia and spasms at 10 months. So that's also another risk factor at times. Now, again, just to touch on the fetal diagnosis, fetal intracranial hemorrhagic stroke and porencephaly. So you're seeing this is a fetal MRI, and this is like the cystic encephalomalacia pocket here. You're seeing the susceptibility images on the MRI, fetal MRI, they are called EPI. So there's these pockets of multifocal bleeds here, and you're seeing this early evolving injury on the opposite side. So there are collagen mutations, which can lead to these multifocal hemorrhages and porencephaly and in utero stroke-like lesions. These are not actually vascular strokes, but these are due to predisposition, genetic predisposition and fragility of the vessel wall that leads to the presentation early on. Now, motor deficits, we talked about the hemiplegic cerebral palsy. It correlates with the type, size, location, and number of infarcts. There's substantial individual variability, and the PVI, the periventricular venous infarction, the leg is more involved, upper extremity more with the arterial lesion, face is typically spared. Now there are, so rehabilitation is physical therapy, occupational therapy, start early on, early intervention programs are really helpful. Early diagnosis is crucial, so education of the pediatricians to identify the early handedness with the neonate, those who don't present in the neonates are the ones that get delayed to the diagnosis and presentation and starting the rehab. There are trials on constraint-induced movement therapy, bimanual therapies, and other stimulation trials. Again, research trials, I'm not going to details of that. Now, language and learning. So families will often think there's one-side stroke, there's only motor symptoms. No, but language and learning can be affected, and they can be in the range of 10% to 30–40%, depending on the extent of the stroke and the extent of the white matter injury. Even though the language in left-sided lesions, we've seen good outcomes and lateralizing to the opposite side, but these children are at risk and they can present with language, learning, autism-like features, ADHD-like symptoms. So all these we need to screen a lot carefully as they present from that 3 to 6 year to the early school years. It's not just the motor disability, and so families need to be counseled for that. Epilepsy, early symptomatic seizures usually stop within the days of onset, and usually more in majority the medications are weaned before discharge from the neonatal ICU admission. The risk of epilepsy is very high. It's 50 to 60% in various studies. Majority will present somewhere in childhood, around the time of puberty, teenage years, hormonal, predisposition with a febrile illness. So all those risk periods are there, but we've seen children present from anywhere from 3 years, 4 years, 8 years, 10. I have a family that came back after many years in teenage at 16 years presenting with symptomatic seizures, that remote symptomatic seizures from the remote stroke. So majority are focal with alteration of consciousness, but sometimes these can be difficult to treat. And I'm not going to do the details of epilepsy management, but if they get refractory, consider early referral to the epilepsy surgery. Now, cognitive and intellectual. So these children, they grow into their deficits. Prevalence is 50 to 60%. Usually attention, processing, executive functioning, organization, verbal retention, all these can be affected. And they cannot be accurately predicted on the lesion, but families should be counseled that this is something that will be clear with time. Epilepsy is also more associated with adverse cognitive outcomes. So a child who's having difficult to treat seizures and is on medication is more at risk. Neuropsychological testing, learning strategies, education supports, those are really important. So neuropsychological testing is indicated when they start into the early school years to diagnose any symptoms of ADHD or other comorbidities that may require some extra support in the school system. Now, parental counseling, parental and family outcomes. So really, there is studies showing that there's a lot of maternal and parental guilt as to why this happened, and families who have children with stroke or who have a admission into the neonatal ICU, they really have long-standing issues with the anxiety and stress related to that admission and to what happened to their child. And also that what I discussed early on, not finding the exact cause or the exact timeline. So clearly state and remind the parents that this injury could not have been prevented and is not their fault, right? Like nothing they did or did not do that led to this. So that parental support for coping is really important to give them hope and to guide them and support them so they can work with the rehab teams to support their child for the optimal outcome. Now, I'm just sharing this story here. So this family, so this is a girl who has congenital hemiplegia. This was her, and now she's like almost 25, 28 years old. And so there was this MRI that was done at birth. So this was like 2 decades back, right? In utero, they had a diagnosis of what was called hydrocephalus. So that was probably the ventriculomegaly from the intraventricular hemorrhage with the white matter injury. And this is her MRI in the first or second year of life. And you see the thinned out white matter with the expanded ventricle. And you see the opposite side. This is the early handedness here, playing the piano with the left hand, holding the right hand fisted. In the grown picture, you can see the leg length difference and the muscle mass difference. And, you know, she's an occupational therapist now. So she's working with children who have similar symptoms to what she grew with. And her mother, who was a nurse, she started that International Alliance of Pediatric Stroke with a group for advocacy and where families share stories and encourage each other with what worked and what did not work, and just disseminating education and information. And with the American Academy of Neurology, one of my fellows also, we worked on this video, which is accessible freely if you go on the AAN website and make an account and subscribe on the YouTube. So this is a small 4-minute video on education on perinatal stroke diagnosis and management, which can be shared by with your students or teams if they want to learn about it. Multidisciplinary care in a stroke program where available. So with the pediatric neurologist, if you can collaborate with the rehab team, having a neuropsychologist available when needed, or having a special education and nurse coordinator, really supporting these families long-term can go a long way in changing the outcomes. So I think that's all, and I'll stop sharing.
Yeah, so thank you, Dr. Sonika, for such an extensive and very elaborate discussion about the perinatal stroke, starting from very important slides about the fetal stroke and then with the neonatal stroke part also. It's very interesting to see about this, the placental, I mean, the placental examination part and finding the abnormalities on the placenta. I think that dates back to our initial MBBS days, where we were taught to look at the placenta also, to look at the etiology of the stroke in that part. And especially about the traumatic vasculopathy, kind of like cause for the stroke in the part. So, I mean, we'll open this part to our experts to the discussion. Just guide us in the kind of like in the gist that what are the cases where you, in practice, where you, I mean, put them on the anticoagulation, especially in cases of arterial ischemic stroke. That's the one thing. And second thing that number of times what we practically find in ICU is this that because these kids are quite sick at times, so they are not getting the MRI done in next couple of maybe the days also. So are we missing anything? So like these cases where you delay the MRI a couple of days and you diagnose a stroke later on the part.
Right. So to answer your first question, anticoagulation is almost never done. So not for neonatal strokes. The case that I presented with the case report that is there had the vessel wall injury and clot due to the traumatic birth. So that's like a total outlier, but usually for the neonatal stroke, by the time we diagnose it, the stroke has happened and the clot has possibly just there's flow, and it's not that the clot is sitting there and blocking the vessel. So for neonatal strokes, the anticoagulation comes into play only for the cerebral sinus venous thrombosis, which is like a separate category, although under that big umbrella. So if there is a CSVT, that also careful consideration on a case-by-case basis, looking at the volume of the hemorrhage. But for the arterial ischemic neonatal strokes, anticoagulation is not indicated and not done.
Right.
Your second question about the babies being sick in the neonatal ICU. So yes, I agree. If the baby is in status and they're seizing, your first thing would be to escalate medication along the status pathway. So you're going from phenobarb and then going to fosphenytoin, midaz infusion, whatever is your pathway that you are following. At Children's Hospital of Philadelphia, we have a pathway and it is accessible on Google. Anyone can look at it and you can adapt and adapt it to your center and use it. And so first thing is stabilize the seizures when they are 24 hours okay, seizures have stopped, that's when we send them down for MRI. So there are certain babies who will not stop seizing right away. So then the MRI gets delayed, but you'll still be able to diagnose, because whether the baby goes on the 3rd day or 5th day or 7th day, the stroke will still be seen. The diffusion will persist for, there is the period after like the 10th to 14th day window where you see some pseudo-normalization where the diffusion may start looking better, where the injury extent could be underestimated. So that period, usually like for the hypoxic ischemic encephalopathy kids, we try to send them for MRI from day 3 to 5, because after that, the pseudo-normalization risk is there. But for, so as early as you can do, but obviously when a baby is in status, if you want bedside imaging, ultrasound is great for hemorrhages, right? Like you can look at the expanded ventricle, you can look at the hemorrhage. In some babies who are unstable, we've done bedside portable CT scans, especially in the cardiac ICU where they are the complex heart kids and they cannot be transported. But again, the quality is poor, but if we see abnormalities on the EEG and we are suspecting hemorrhage, and we want to look, then those are the 2 bedside tests that can be considered.
True. Thanks. So I would like to invite our experts for today, Dr. Tuga, Dr. Minal, and Dr. Lokesh also. So hey, good evening to all of you. To have your comments about the part, Dr. Tuga, please.
Hello everyone. Thank you very much, Dr. Agarwal, for this nice and excellent presentation. I'm curious about that, your suggestion. Recently, there are some publications shows sodium channel blockers is more effective in neonatal arterial ischemic stroke than first-line therapy, like classical therapy, phenobarbital, something like that. What do you think about that? If the patient had ischemic stroke in neonatal period and presented with some seizure, especially status epilepticus, do you think as a first-line therapy, kind of the sodium channel blockers, phenytoin and similar medicine instead of classical first-line therapy?
So as much as I've read the literature looking at neonatal seizures, most widely accepted and approved, and what neonatologists and neurologists world over are comfortable using is phenobarbital as the first line. And then in our pathway, we have fosphenytoin as a second line. But I think it might need to be more prospective trials, which are always very hard to do in this young neonatal population. So I feel like phenobarb is majority, like at least here in this part of the world we've seen, and I hear from neonatologists when I give talks everywhere that they are also comfortable using phenobarbital as the first line. The one thing with the sodium fosphenytoin is if you're not sure the baby has a stroke, if there is one is the cardiac effect, right? Like babies who have congenital heart, can actually have side effects worse from the phosphenytoin. Also, with phosphenytoin, if the baby doesn't have a stroke and it is a genetic epilepsy, sometimes that can be another contraindication, relative contraindication of which child you can treat with a sodium channel blocker or not, right? Like, so I think what I've, in my experience, phenobarb has been on the top everywhere.
Thank you.
Thanks. Dr. Lokesh?
Yeah, thank you, Dr. Sonika, for that wonderful talk. I think you alluded to the clinical correlation and long-term outcomes, which is very important while counseling these families as to what does that imply. And one of the important thing I want you to reinforce is what are the basic minimum investigations when you see a neonatal stroke that one has to consider to be done. Second part is there a role of transcranial magnetic stimulation as part of rehabilitation later on? And is it accepted form of therapy because age group and other things less than 10 years, is it accepted?
Yes. So the basic investigation would be, so, you know, when a baby is presenting with seizures and encephalopathy in the neonatal period, even without whether they have a stroke or not, they'll get the basic labs. So CBC, CMP, the electrolytes, looking at calcium, glucose, and then the basic for if you're suspecting a hemorrhagic stroke. So the basic you can do is PT, PTT, INR if you have to look at that. And then your next step, sepsis evaluation, only on a case-by-case basis. So whether the neonatologist is suspecting sepsis or there are signs in the mom's history looking at that, then we recommend lumbar puncture and other sepsis related tests. And then neuroimaging is your diagnostic test, which is like the gold standard, and the however best you can arrange after stabilizing the seizures, and if the child is okay for transport, then MRI brain with the vascular imaging added, MRI, MRA, but MRV on a case-by-case basis. If you're seeing a big hemorrhage or a deep hemorrhage, that where you are suspecting a sinus venous thrombosis. But the rest of the hematological labs, the chart that I showed is like rarely done. It's only on a case-by-case basis where there's a history to suggest a thrombotic or other thrombophilia or other disorder based on the family history of clots and recurrent pregnancy losses, or the baby has extensive hemorrhage and clot burden where we are suspecting something.
No, thank you. And regarding the transcranial magnetic stimulation?
Yes, so that's, again, it's clinical research. It's not like the standard of care, but majority of the centers, they have these either constrained movement trials or the transcranial stimulation. All these are currently in trial phase, clinical research phase.
Thank you.
Thanks. So we have Dr. Minal, would like to have your comments.
Yeah, first of all, let me congratulate you, Dr. Sonika. Very wonderful and a comprehensive lecture, really great. So I have a question pertaining to the treatment, although you did cover briefly. When is it that you would actually consider initiating an antiplatelet agent in neonatal arterial ischemic stroke?
So that's, so for the, without infection, without congenital heart disease, just like the idiopathic neonatal arterial ischemic stroke, we're not doing any of those treatments, either anticoagulation or aspirin or anything. Now, if there is a congenital heart kid who has an ongoing risk factor for clotting and propagating, those are the children where on a case-by-case basis in conjunction with the cardiac ICU team is where the anticoagulation and other antiplatelets are considered. not for these neonatal strokes, which are thought to be hypothesized due to a clot from the placenta that goes and blocks the vessel. It's a one-time and done, and the chance of recurrence is almost not there, and less than 1% or so. So these are not the children who need ongoing antiplatelet or anticoagulation treatment.
On the same lines, let me also ask you how you would manage neonatal cerebral sinovenous thrombosis. When would you actually consider anticoagulation, and when do you consider going conservative? If you're going conservative, how do you monitor them?
Yeah. So if you're going conservative, you have to do a sooner neuroimaging to look for clot propagation and flow. So then we image in 5 to 7 days again with the MRI, MRV to look for the venogram to make sure that the clot has not increased and there is flow which is improving. Now, anticoagulation, there are studies from many countries, and so the Canadian studies, they go more in favor of anticoagulation sooner. We've seen some so if you pull up studies and data from different countries, you'll see a different approach. But yes, CSVT is one indication where we will be anticoagulating unless there is a huge hemorrhage, which can be a relative contraindication based on the burden. Again, you have to weigh in the risk and benefit. Hematology usually gets involved, and the majority of these babies will be getting Lovenox, and then it's usually up to 3 months or so. So, and then close follow-up of the labs, and then they come and we wean it off. Again, repeat imaging in 2 to 3 months, and then wean it off. Take it off then.
Great, thanks. How often have you actually come across congenital thrombophilic or prothrombotic disorders in perinatal or in neonatal strokes that actually warrant a long-term kind of anticoagulation? Do you see it very often?
No, very rare. I can just remember, like, from if I see a recent memory of 7 years, it's like 1 or 2 cases I've seen.
Oh.
Yeah. So these are extremely rare. So majority of these neonatal strokes are a one-time and done, and the future risk is not there. So it's more of the rehabilitation and long-term support and just following them over the years and encouraging the parents, because this is the one condition where you really see good outcomes. So yeah, the picture that I showed, she's an occupational therapist, really smart, and she doesn't have seizures, but she has a very significant hemiplegic gait and asymmetry in the leg. If early in utero strokes can lead to that asymmetry, but the neonatal strokes, if with early rehabilitation and care, you don't see that limb length discrepancy. It's more the in utero type of injuries that lead to that.
True. Thank you so much.
Right. Thanks a lot. So maybe just expanding to the last Dr. Meenal's questions there, like, because you get a lot of CSVT with the anticoagulation dilemmas on the part. So just one of my queries is that, like, once you see a child with the CSVT and having multiple sinuses involved on the first MRV only, does it make you more, kind of like keen to put them on the anticoagulation or not on the part?
Yes, and because if there is a high clot burden, they often will end up on anticoagulation.
So we have a couple of questions in our question answers. We can take that and then we can go out to our the case presentation, and I would request Dr. Sonika to be, because we'll have interesting cases over there. So the one question is, I'll just read the questions. The one question from Dr. Patra: is hemiplegic CP is a form of remote perinatal stroke?
Yes. So hemiplegic CP is presentation of a remote perinatal stroke. It can also happen from any white matter injury which is unilateral. But like the pictures that I showed of the classic left or right MCA strokes, they are the ones that lead to the hemiplegic cerebral palsy on the opposite side. Earlier, these kids were diagnosed with what we call congenital hemiplegia. So that's the presentation if they don't present with seizures at early life.
So Dr. Harshati asked about any experience of using erythropoietin for perinatal stroke. I think you mentioned about this molecule.
Yeah, we've not used it. There's preclinical trials in the labs. Yeah.
Dr. Suresh has the similar question. I think we answered any antiplatelet role in arterial stroke in neonates. I think you mentioned it very clearly that we don't require it in most of the cases on the part. And again, Dr. Patra had a question about metabolic screen in patients with a stroke with encephalopathy. Like, do we normally do ABG, ammonia, TMS, urine GCMS kind of thing in a child who has got a stroke-like features and he is encephalopathic also?
What is urine GCMS?
Urine organic acid analysis.
Oh, okay, organic. Yes. So actually, you know, because of time, I skipped that slide, but that's a very important question. So metabolic and genetic studies are done on a case-by-case basis where your neuroimaging or clinical picture is looking atypical, right? So you're thinking of a stroke, but it's not fitting. The focal motor seizures are there, but the MRI shows a pattern of injury, which is more seen in metabolic disorders, bilateral, symmetric, non-specific kind of injury that is seen. So when your imaging and clinical picture doesn't match, or there are seizures which are not responding to multiple therapies and escalating the pathway for seizure management, where the EEG shows patterns where there's, where there's worsening EEG pattern or some typical EEG patterns that suggest metabolic disorders. So whenever your clinical course and neuroimaging is not matching, then that's when we expand the workup for the metabolic disorders. Now for genetic, which I mentioned, the COL4A, right? So you see a baby present with seizures, you do an MRI, but you don't see diffusion restriction, but you see old injury like the ones I showed you with the fetal scans, right? Like you're seeing cystic encephalomalacia, porencephaly. So these are not acute neonatal changes. These are remote injury, and that's when we expand the testing to include the COL4A or other genetic conditions.
Quite interesting. I think we've got a couple of questions more. Some we can answer in the chat box and we can discuss while the course progresses. So we'll start our the interesting cases. So we have got 3 cases. Dr. Pravda from Turkey, Dr. Ranjita from our Jailin Devangiri, and Dr. Jagdish from C. Raman Institute from Chennai on the part. So I would like to invite Dr. Parvira from Turkey to present her case, and Dr. Tugba will be moderating the case.
Will we request all of you to keep sticking to 5 + 2 minutes, please? Present your case in 5 minutes, restrict the discussion part, and 2 minutes for the moderator and discussion. So please keep to 5 + 2 all.
Good evening, everyone. Thank you for your kind invitation. The patient I will present today is one day-old girl baby. The perinatal history was unremarkable. Only Apgar score was 7 and 8. Was given to the mother after delivery, but after needing oxygen, was transported neonatal intensive care unit. And on the 8th hour of monitoring, was observed distillation, tachycardia, and movements in the form of lying and swallowing. Due to seizure, EEG was connected and consulted to us. In neurological examination, motor reflex not obtained on the right, no grasping reflex in the right upper and lower extremities, and cortical fisting on the right hand. On EEG recording was observed in the left hemisphere, 12 seizure activities and sawtooth appearance. In the right hemisphere, 2 subclinic seizure. After this, phenobarbital and levetiracetam were loading respectively, and was recommend an emergency cranial MRI. After levetiracetam loading, we saw sleep-wake cycle has started to occur in the right hemisphere, but 9 seizure activities in the left hemisphere, and sawtooth appearance was still present in some areas. In the conventional neonatal EEG, we saw asymmetry between hemispheres. Was observed that the left hemisphere was more depressed and interrupted than the right hemisphere. And during this recording, we observed ictal activity. I want to show you video. At the same time, in the patient became sluggish, had automatism in the mouth and arms, and mild cyanosis. During this ictal activity, we saw rhythmic build-up delta activity started from midline CZ electrode position and rapidly spread to the left and right hemisphere. We can see here seizures. And its EEG result, as I explained before. Due to these recurrent seizures, phenytoin was loaded, and in emergency MRI was saw middle cerebral artery stroke. Was observed a large area of diffusion restriction in the left frontal, parietal, and temporal lobe, and left basal ganglia at the location corresponding to the MCA irrigation area on the left. We can see these changes in the different sequences of MRI and its MRI report. After loading phenytoin, we was observed the left hemispheric status changed to dysfunctional left hemispheric rhythm, and the functions of the right hemisphere were completely normalized. We saw cycle wakes, sleep wake cycles in the right hemisphere. No seizure activity was observed in the 48 hours, and EEG recording was terminated. For etiology, we performed some tests. These laboratory evaluations were non-pathogenic. The MCA stroke was considered to be possibly caused by perinatal hypoxia. For treatment, we continued phenobarbital, levetiracetam, and phenytoin. Anticoagulant therapy was not recommended. Physical therapy and clinical follow-up was recommended, and physical therapy was beneficial. Today, this patient is 3 years old, and in neurological examination is normal. Only she used her right arm less, and as anti-seizure medication, taking only levetiracetam today. This is last EEG. Asymmetry continues still, and we can see that the left hemisphere is depressed than right hemisphere. Thank you for your attention.
Thanks, Dr. Prouda. So we can have Dr. Tugba for the comments.
Thank you very much. Again, this nice presentation. We brought this patient to remind again. As Dr. Agarwal told and recommend us, if the patient has beyond the clonic seizure, some motor seizure, if the patient has some autonomic features like apnea, cyanosis, and also as well as some automotor features, these are usually slight and subtle in neonatal period, but we should careful if the patient has appetite is less than and hypotonia, and additionally this kind of subtle features, we should evaluate very carefully neurological examination as well as AEEG or conventional EEG to clarify if the patient has some ischemic stroke, MCA stroke, or something like that.
Thanks. Quite interesting. So we move to our next case, which is from General Medical College, Davangere, India. Dr. Ranjita will be
We
presenting.
can ask for comments from experts. Dr. Sonika and anybody else, please ask the comments right now.
Can I ask a question of for the prior case, like the child is 3-year-old and they are on Keppra, still on the levetiracetam, or they are still on medication for seizures?
For our patient, Dr. Agarwal?
Yes.
Yeah, she has still some infrequent seizures. So,
Okay.
yeah, continue as a low dose as a levetiracetam.
So when after discharge, was she just kept on the medication, or
Yes.
did she present back with seizures?
No. Never we stopped the levetiracetam.
Okay.
Any other comments you have? Dr. Kesh, Dr. Minal? Okay. Can we move to the next case? Dr. Ranjita from Davangere and Dr. Asha will be moderating this case. Dr. Ranjita, please. Yeah.
Good evening. I will be presenting case under the guidance of Dr. Asha SM, unveiling the fate of neonatal stroke. A 1-month, 2-day-old female infant presented with complaints of fever, vomiting for 1 day, and 2 episodes of right-sided focal convulsions. The infant was well between the episodes of convulsions. She was the second living issue of a 3rd-degree consanguineous marriage. Antenatal scans were normal. Term gestation delivered through LSCS with a birth weight of 3 kg. Baby cried immediately after birth. The perinatal transition was uneventful and the infant was exclusively breastfed. On receiving, the infant was actively convulsing. On examination, severe pallor was noted. CNS examination revealed weak cry, decreased activity, hypotonia, and absent reflexes. Infant continued to have 3 more episodes of convulsions, aborted with 2 anti-seizure medications, requiring maximum dose of injection phenobarbital and injection levetiracetam. A start dose of injection vitamin K was given intravenously. Differentials considered at this point were late onset vitamin K deficiency bleeding, liver disease, congenital factor deficiency. Investigations showed severe anemia with a hemoglobin of 4.2. Coagulation profile was deranged with prolonged PT, that is 61.1 second, normal APTT 16.5 seconds, and raised INR 6.2. For the management of acute bleeding, 1 FFP and 2 split transfusions of PRBC were given. As part of evaluation, whole exome sequencing was sent. MRI brain with angiography was done once the baby was stabilized. Here, we can see large areas of diffusion restriction in the left fronto-parieto-temporo-occipital lobes with mild T2 flare hyperintensities. On the right-hand side, there is evidence of bilateral subdural hematoma in the convexities of fronto-parieto-temporal occipital regions. A repeat coagulation profile was done after FFP transfusion, which still showed isolated prolongation of PT greater than 120 seconds with INR being raised. Isolated PT prolongation narrowed the diagnosis towards factor 7 deficiency or liver pathology. As vitamin K deficiency bleeding results in both prolonged PT and APTT, which was not seen in the above case, vitamin K deficiency bleeding was unlikely. The infant was well between ictal states and did not have any other systemic disturbances related to liver failure. Liver function test was normal, hence liver pathology was unlikely. As factor 7 has the shortest T half of 3 to 6 hours and is known to cause CNS bleeding, possibility of factor 7 deficiency remained high. Whole exome sequencing reports revealed factor 7 deficiency with homozygous single base pair deletion in exon 8 of the F7 gene, which confirmed the diagnosis of factor 7 deficiency. The take-home message we would like to convey here is, in the evaluation of neonatal hemorrhagic stroke, although rare, but factor 7 deficiency must be considered along with the common causes as it is a treatable condition. Thank you.
Thank you, Dr. Ranjita. I think Dr. Asa will have some points to make.
Yeah, good evening to all of you.
Asha, 1 second. Ranjita, stop sharing the screen so that we can see Dr. Asha. Yeah, thanks.
Yes.
Yeah.
Thank you, Dr. Ranjita. That was a wonderful presentation. Here I would like to add that all the investigations pointed towards factor 7 deficiency, but still we could not give factor 7 concentrates to the neonate as it was not available, and also the cost is too high, that is recombinant factor 7, that is Novo 7, which is not available at our center or in our city, and also it's too costly and patients were not affordable. Hence we managed with FFP, and this child was thriving well for a month duration, and child again came back with the skin bleeds. That time it was more of a ecchymotic patches, and then we again repeated the coagulation profile, and INR was deranged with isolated PT prolongation. So this child was referred to higher center, but unfortunately child started having status epilepticus, and it didn't respond to anti-seizures, and midazolam infusion was started. And at their center, they had done factor 7 assay, which showed very significantly low. That was 1.8%, normal range being 50 to 150. But still, this child could not receive factor 7 concentrates at the right time, and child succumbed to death. So here is the main role of with factor 7 was available, we could have prevented, and this child was discharged with initially with the 2 anti-seizure medications and was well for 1 month.
That's interesting. Dr. Sonika, our experts, comments?
Can I ask a question if you don't mind, Dr. Praveen? Now,
Sure.
this is a very nice case, but I think she mentioned a subdural bleed. That's very interesting.
Yeah.
So subdural, right? So subdural is generally not included in hemorrhagic stroke, if I remember. It is intraventricular, intraparenchymal, subpial, subarachnoid. Subdurals are generally traumatic because. Can Dr. Asha clarify?
Yes, ma'am. Actually, with the imaging findings, even we had a doubt whether it is subarachnoid or subdural. But after discussing with the radiologist, they were more of subdural. But even I was not convinced with the subdural finding, ma'am. It could be even subarachnoid also.
I think for our students, I just wanted to explain that generally subdurals are not included in the definition of hemorrhagic stroke. Wouldn't you agree, Dr. Sonika, Dr. Lokesh?
Yeah, so the hemorrhagic stroke, which we discuss classically under the umbrella of neonatal stroke, is more the intra, which is in the parenchymal, but they can be multi-compartment hemorrhages. So what we see sometimes subpial hemorrhages between the subpial layers, they can be extraaxial, intraaxial, both. So that combination you can see in certain complicated and traumatic deliveries or in a baby who's predisposed to bleed, right? Like, so multi-compartment hemorrhages. Small amount of subdurals can be seen in normal deliveries. If you do an MRI for some other indication, tiny amounts of subdurals are part of normal birthing process. So I don't know how much your volume was pretty significant in that area. So that's probably not beyond the normal variant. But multi-compartment hemorrhages they can come under the umbrella of, describing hemorrhagic stroke sometimes, because we are increasingly now seeing more of the subPLs also, which are getting recognized. These babies are a part of what they present with seizures. But the outcome for the intraparenchymal is different from the extra-axial ones. But many are usually associated with each other. So you see it in multiple compartments. You really cannot isolate them.
Yeah, they are not isolated. That's true. Also, subpile bleeds are probably more common when you have bleeding into temporal lobes. That's quite common, especially when they tend to be associated with venous infarcts.
Okay, I think thanks, Dr. Ranjita and Dr. Asha, for this interesting case. We move to our third case because we got some paucity of time also. So Dr. Jagrith from C. Ramachandran Institute, Chennai, will be presenting his case, and Dr. Ranjit will be moderating, will be his guide for the part.
Yes. Hello, good evening, everyone. I am Dr. Jagrith. I'll be presenting an interesting case under the guidance of Dr. Ranjit sir and Dr. Uma Maheshwari ma'am. So we had a neonate who was born to a 37-year-old mother. The antenatal history was pretty much insignificant. The mother was diagnosed to have herpes zoster and treated with a tablet acyclovir at 22 weeks of gestation. And other than that, she just had gestational hypertension and gestational diabetes mellitus. It was an elective LSCS in view of previous LSCS. The baby was pretty much normal, 3.16 kg. It was initially taken up for NICU for observation to rule out if there are any signs of congenital varicella syndrome. At around 3 hours of life, we noted the baby to have pustular lesions with macular rashes over trunk and extremities. Since there was a history of herpes zoster in the mother, we did a Zank smear, which did not reveal any multinucleate giant cells. So we diagnosed it as a case of transient neonatal pustulomelanosis, and it eventually subsided on day 2, and we shifted it to mother's side. But on day 3, we noted the baby to be lethargic with poor suck. So we did the septic workup, which was negative, but we had already started on IV antibiotics and antiviral considering the previous history. But on day 4, day 5, we noticed the baby to have refractory seizure, which were not even getting controlled with 3 anticonvulsants and required a midazolam drip. The CSF analysis was normal. The metabolic panel was normal. And slowly, gradually, the baby progressed into a multi-system involvement where the diastolic BP was very low compared to the systolic. There was wide pulse pressure, which required almost 5 inotropes. Then the baby developed acute kidney injury, which required peritoneal dialysis, followed by disseminated intravascular coagulation. And eventually, the baby succumbed on day 11 and day 12, on day 11. So the MRI brain, here you can see that there are areas of bright signal on diffusion weighted imaging, which involves the bilateral periventricular and subcortical regions, which also involves the basal ganglia, posterior fossa structures, and this could indicate edema, inflammation, or infarction. This multifocal diffusion restriction can also be due to the microvascular infarcts. And in the right hand, you can see GRE blooming images, which indicates capillary fragility and microbleeds. So based on this, these were our differential diagnoses which we kept. I have intentionally hidden the first one. We'll go to the other 4 that based on the previous history, we thought that could be a case of neonatal HSV encephalitis, but the refractory seizures was not fitting into this. Then we thought chikungunya encephalitis and neonatal lupus and neonatal sepsis. So on day 6, we noted this type of classical rash on the baby where you can see linear whorl type of rashes along the developmental lines of skill migration, which we call the Blaschko lines. This occurs due to melanin leakage secondary to apoptotic damage to the basal keratinocytes. These dermal macrophages engulf this melanin, leading to this type of pigmentation. So I think based on this image, we may pretty much sure of narrow down our diagnosis to nothing but incontinentia pigmenti. Here I wanted to make a point. This was MLPA, which we did based on our clinical findings. We need to note that not every case, every genetic case which we suspect whole exome sequencing would be the answer. Again, we need to make a clinical diagnosis first and then base our genetic workup based on that. This also indicates on various other disorders like DMD and SMA. So the discussion part, this is an X-linked dominant disorder which primarily affects the females, and it is very lethal in the males, which they eventually succumb in utero. This is a mutation causes the loss of the function pneumoprotein, which leads to the failure of the nuclear factor kappa B activation. This makes the ectodermal cells highly sensitive to tumor necrosis factor alpha and other pro-inflammatory cytokines, which make the cell prone to apoptosis with even mild form of stress. So even though by placing emphasis on skin manifestation by the name incontinentia pigmentae, somehow misrepresents this disease. In incontinentia pigmentae, the most significant medical problems come from the involvement of eyes and brain. So even though we place this more of skin manifestation, but the most dangerous symptoms is occurring in the brain. So this here we can see that there will be pneumo normally protects the cells from cytokines in incontinentia pigmentae, where pneumoprotein is deficient, these cells become more vulnerable to cell death and inflammation. Contrary to expectations, neurons and glial cells don't always undergo apoptosis despite the pneumo deficiency. Even in the MRI images which we saw, there were only few areas which were involved and relatively other areas were spared. This is because due to the unfavorable lionization in the brain, this means the certain area of the brain express the mutant X chromosome, making them more vulnerable. And these areas experience more of endothelial apoptosis, ischemia, and infarction, which make them prone for neonatal stroke. So now the question is, why are patients with IP more prone for seizures? One simple thing is ischemic stroke is able to trigger epileptic seizures, but however, this frequency of seizures in IP is higher than what would be expected on the basis of this well-known association. So what the basic thing which is being told is that there is a severe disruption of the blood-brain barrier due to the endothelial cell dysfunction, which promotes this seizure activity. Across this leaky blood-brain barrier, plasma proteins such as albumin extravasate into the parenchyma and activate the astrocytes, which are then less able to maintain potassium and glutamate homeostasis. So again, management is again a big question mark. There is no set guidelines in managing this IP. The first and foremost is control the seizure as soon as possible, because seizure causes apoptosis, and apoptosis in IP again triggers seizures. Then maintain cerebral perfusion, consider corticosteroids. It is again a big debate whether we should put the patient on a maintenance phase of corticosteroids or use it only in acute phase of vasculitis. In long-term follow-up, monitor for focal deficits, avoid recurrent seizures, inform the family in risk of future pregnancies. The future, again, there are many things in pipeline, nothing is yet been proven. Each therapy has its own challenges, like in gene therapy, because of mosaicism, we are not able to utilize it in a practical way. Anti-TNF, we have drugs, etanercept and infliximab already in the market, but again, this is only a theoretical and is not recommended in use. And anti-VEGF is only to maintain the ophthalmologic component of IP, but cannot be used in other settings. So again, I'll open up the discussion on how to manage this and whether any set guidelines we have in managing this condition. So thank you. This was my presentation.
Okay. Thanks, Dr. Jaquith. It's a very interesting case to have presented like a stroke, and you found by the clinical evidence of incontinentia pigmentae, which requires a different kind of management approach. So Dr. Ranjit.
Yeah, yes, sir. Can you hear me? Yeah.
Yeah, we can hear you.
Thanks, Jaquith. He's a neonatology postgraduate. Excellent presentation. Actually, this case was born outside, and doctor parents, they were referred to us at little later stage of presentation. So when the child came to us, the skin was masked with a lot of creams and the liniments which has been applied. So we couldn't make an instant diagnosis. So based on the imaging finding, we even kept a possibility of chikungunya neonatal encephalitis. But when we reviewed the past pictures, the diagnosis was instant. And the child, because of poor prognosis, the care was redirected and went to an outside hospital facility, and the baby ultimately succumbed actually. So this baby didn't receive any anti-inflammatory therapy. I would like to hear from experts, what will be the role of anti-inflammatory therapy, to how much extent we will go in such a presentation of neonatal incontinentia pigmentae? Thank you very much for an opportunity.
Thank you. I'll just coming in between. Thank you for amazing cases from all of you. And, so you'll be sent the certificates will be mailed to you. I just wanted to request all the experts. Why I pitched in between was, besides your comments for the case, I want take-home messages to be also given because we are already, we are already 12 minutes past time. So the comments on this case and then also the take-home message. Yeah. So I think Dr. Sonika, you are the showstopper, so it comes to you first. Yeah.
Yeah. So I think so I have taken care of one patient with incontinentia pigmentis, extremely rare, right? But they usually get strokes multiple times in that phase, and then usually supportive care is the main thing, right? There's not like a specific therapy. I know the presenter presented everything that is in the pipeline that is undergoing research, but mainly it is the cerebral palsy that comes out due to this multifocal bilateral injury, seizure management, rehab. That's the long-term treatment. There's not like a specific disease-specific treatment. But the take-home messages overall for neonatal stroke, I would say is, in the neonatal period, stabilization, treatment of seizures, once the baby is stable, to make your diagnosis, early imaging as is feasible, whatever's available is really important, because for counseling and long-term rehabilitation guidance and counseling the family, that is really crucial. And usually majority of these strokes do not need any anticoagulation or any therapies, except for long-term rehabilitation, management of seizures when they present. In majority, stop the seizure medication about a week or so after the seizures have stopped. Sometimes phenobarb, we just stop it right away. We don't even have to wean, it's long-acting. And rarely I've had to start it again if for a one-odd baby who represented with seizures and then you wean it off in the clinic. But this is also acute symptomatic seizures that does not need long-term seizure management unless they present again with epilepsy, because treating the early symptomatic neonatal seizures and continuing that treatment is not going to change the outcome of the presentation of epilepsy. So we restart the anti-epileptic treatment where epilepsy drugs or seizure management is done based on presentation again. So that acute symptomatic seizure, there's no need to continue the medication beyond. Those are like the big basic points, I would say.
Thank you. Thank you. It was a very amazing and comprehensive talk and wonderful discussion. Thank you so much, Dr. Tuga.
Thank you very much again. I would like to remind and take on message to for all of them. The classical symptoms of the seizures in the neonates, some motor seizures, clonic seizures, and other types of the motor seizures. If the patient has, and the critical patients, we should, if possible, do the neurological examination daily to understand some kind of the asymmetrical neurological examination, or the patient have some subtle symptoms like autonomic apnea, cyanosis, or some kind of the movements, we should suspect some MCA infarct. We should be careful neurological examination as well as AEEG or conventional neonatal EEG. We should apply to do early diagnosis. Otherwise, the complication is very serious. Thank you very much.
Thank you so much. Dr. Meena?
Yeah, I think these were all excellent case presentations, and the take-home message from Dr. Sonika's lecture as well as these cases would be that any child who has focal seizures, particularly anywhere between 12 hours and 72 hours, and is encephalopathic, should be kept as being very suspicious for a possible neonatal or a perinatal stroke. The investigations that we send for neonatal stroke should also be very judicious, and as Dr. Sonika mentioned, thrombophilic workup is not really indicated for all The third thing is, again, as she said, that the treatment should mostly focus on management of symptomatic care, acute care, and not so much on antiplatelets or anticoagulants. The main crux of the treatment is, however, going to be long-term neurorehabilitation, because that is going to be required on an ongoing basis. Basically, hyperacute therapies have zero role in neonatal strokes for two reasons. One is that in most cases, we don't know when is the onset. We are not really able to tell that this was the time when the stroke onset started. And even if you know what is the onset, we don't have those devices or catheters that we will use to do mechanical thrombectomy. So definitely the treatment should focus only on the rehab measures and management of acute symptoms and stabilization. Great presentation. Thank you. Thank you, Shefali Madam and Mahesh, for the invitation.
Thank you, Meena. Thank you. Mahesh, any comments? And then we'll come to Praveen for your comments.
Ma'am, very wonderful cases today, ma'am. Again, I wanted to just say that in our setup, in any hemorrhagic stroke in neonate, we should always rule out vitamin K deficiency, ma'am. It's a very common and treatable cause. So that's one point. Second is when this hemiplegic cerebral palsy because of stroke, because of epilepsy, early surgeries like functional hemophilia can be a great intervention, ma'am, to give long-term good outcomes. Thank you, ma'am.
Thank you, Praveen.
Fine. I think we had a very good amalgamation of cases and a very nice discussion by Dr. Sonika about the part. So as clinician, I feel that our neurology colleagues do the basic job very wonderfully, like managing them, the vitals, and managing their symptomatic, complications on the part. As a neurologist, we feel that we should not be missing the tiny bunch of CSVT, which is progressive on the part, because there only comes the role of your anticoagulation. So we keep an eye on those cases where which are definitely small in number, but we should not be missed because they have got some amount of definite management in a way.
Yeah, thank you. I think it was a wonderful session, and I'm really grateful that all of you have joined. And for as I mentioned earlier, Dr. Sonika would be coming to New Delhi and we'll be talking about fetal neurology, something which is, I think, closer to her heart than neonatal stroke. And the quiz is open, so please, and you'll be having mailers sent to you, so you can apply for the quiz, which will be there in the conference. And thank you so much. And one thing I just wanted to mention that we have to think of start the early multisensory stimulation right from the NICU, and then we have lots of neuro rehabilitation going on, a lot of technological advances, which AR, VR, AI based, and many things have come up. So we have to do it, and all this modified CIMT will virtual reality assist, panic. We also have doing with transcranial magnetic stimulation, all those things we have been doing in research mode and all, and now we are putting in practice mode. So I think it is there even in low research settings, and we can do, and we have to just ensure that the maximum recovery possible, what is going to be there, will happen with neuro rehab. Thank you. So this NeuroWiz, the ultimate pediatric neurology quiz, and the quiz master is here, Ranjit. So you see the title of his case was exotic, which is always exotic. So the quiz is going to be exotic too. So he's our copyrighted quiz master. So we welcome you all, and we can end up. Have a nice day, Dr. Sonika, and for everyone, because they are from different time zones. Good evening and good afternoon and good morning. So welcome you all for the AOC, ASEAN, Asian Oceanian Child Neurology Congress. Yeah.
Thank you very much.
Thank you. Thanks.
Thank you, ma'am. Thank you.
Thank you.
Thanks to you.